I'm really, really happy to be handing over to Claire Harrison, who's going to be chairing the panel Q&A. We've had a vast number of questions, which sadly we won't be able to answer all of them right now, but we will get back to you in due course. Can I just remind you, please, that the clinicians here will not be able to answer any personalised treatment plans or comment on any blood tests. Those need to go back to your own haematology team. And over to you, Claire.
Well, thank you very much, Nona. Great job and chairing, and thank you to all the speakers. I just want to introduce a panel today, which includes most of the Guy's MPN team. So as you see us on the screen, top left is Dr. Dipti Radia, then Dr. McLaunan, then Dr. Natalia Curto Garcia, Claire Woodley, who you've already heard speaking, Abby, who gave us that fantastic talk, which I will be listening to again and practicing, and Roselle, who works alongside of Abby. And you've already met also Adam Mead, who's I can see is getting a nice cup of coffee, and Professor McMullen, who is in the hospital. All the rest of us, you can see we're in our homes today. But Professor McMullen has done a ward round and is joining us on the phone. So thank you so much to everyone who has submitted questions. You will be aware that we pre-recorded to avoid technical glitches the presentations this morning, and you will be aware that the situation with regard to relaxing of lockdown, etc., has been changing in the last 24 to 48 hours. I think this just really illustrates the fact that you need to keep up to date. There's plenty of ability to search information on the internet. And if you're not sure, to reach to your clinical teams, but remember that we can't always give advice about your individual situation. So I'm trying to group the topics of the questions, largely because there are so many of them. We do have an hour for this panel, but it will be a challenge for us to get through all of them. So I'm going to go around the panel asking everyone in turn, and we'll try to come to some of your questions that are have been submitted this morning. If we can't, and we haven't answered them in the context of another question, we will try to send you a response. So the first question then for yourself, Dipti, is about injecting EPO. So for those of you who don't know, erythropoietin is a hormone that triggers red cell release. So the question is it possible to inject EPO into blood to help immature blood cells reach maturity?
Thanks, Claire. I guess one of the issues is that we do use EPO in situations where we can boost the bone marrow to make more red cells. It's not injected directly into the blood. It is given subcutaneously as an injection into just in the subcut tissues, and it works by boosting the bone marrow. So it's not given intravenously. And for those patients who have the marrow reserves, it will help with the anemia by boosting the bone marrow to make more red cells.
Great. Well, thank you very much. So apologies, I will mute my phone. Donal, a question for you. So your special interest is in transplantation as well as MPN. This is a question about graft versus host disease. Perhaps you could explain that to the non-transplant audience in your answer as well. The question is, if after transplant you get GVHD a year later, have you got it for life? This is from somebody who's 68 at the present time.
Thank you, Claire. So with graft versus host disease, the overall risk after transplant for myelofibrosis of all types and stages is around 30%. And that ranges from something very mild to something more severe that requires intensive immunosuppressive therapy. The graft versus host disease, we historically called it acute graft versus host disease, and that's when the immune system of the donor that's been used for the recipient reacts against the patient and can cause skin rashes, liver abnormalities, or diarrhea and nausea, most commonly within the first 3 months after transplant. After the first 3 months, any organ or system can be affected until the patient becomes tolerized to the new immune system. So graft versus disease can occur any stage after transplant. It's more uncommon to occur late without any antecedent graft versus host disease, and often it can be present for many months until the patient becomes tolerant to the GVHD.
Okay, well, thank you very much. Great answer. Natalia, there's a question here about taking hydroxycarbamide. The question is, if I take hydroxycarbamide and my platelets stay below 450, can I stop taking the medication?
Hi, can you hear me? Sorry, just testing.
Yes, we hear
yeah,
you.
I will. So I think you should carry on taking the medication, because that means your platelets are well controlled, and that's the main objective to having the medication, is to prevent any complications. So my answer is yes, you should carry on. You can adjust the dose, but obviously that needs to be discussed with the team that's taking care of you.
Good. Thanks very much. I like to think about hydroxycarbamide a bit as like a blood pressure medication. If you stop taking it, your blood pressure will go back up. Claire Woodley, a question for you. This is about a patient with burning feet. The patient also mentions ringing in their ears, but let's maybe focus on burning feet in the first instance. What actions do you suggest that a patient can take to avoid having burning in their feet?
So some of the kind of non-medical interventions that can be used can involve cooling the actual feet. I wouldn't recommend putting them straight into ice cold water, as this can sometimes reduce the integrity of the skin. Perhaps something like filling a plastic bottle with cold water and rolling it under the feet might help. Massaging the feet might help and improve some of the circulation down to the feet. Some patients have tried acupuncture to see if this can help. There's also the possibility of using some creams on your feet, sometimes some creams with a mild capsaicin element to them can help with reducing the sensation. And then for some patients, it's actually treating the underlying blood count.
Okay, great. So another name for that is something called erythromelalgia, isn't it? So if you read stuff online, you might see about that. So Abby and Roselle, I'm going to ask you a question together, actually. So the question really is about apps. And are there any apps that you think are helpful for, well, patients and staff or family members to use in terms of using some of these breathing techniques that you spoke to us about today, Abby, for helping with anxiety?
I think one of my favourite apps is an app called Headspace, which I do believe recently they were doing free trials. I'm not sure if that's still continuing. But there's lots and lots of different exercises on there. There's breathing exercises, there's exercises to help you let go of very difficult thoughts and emotions you might be having. And you can really get to pick if you want to do short exercises or longer ones. There's a real variety there. So I think most people that go on that app find there's something that suits them and something that helps with what they're looking for.
And I can add to that by suggesting something called ACT Companion, which takes on board some of the suggestions and ideas that were made in the presentation today. It gives you a daily reminder to be able to remember to do some of your breathing exercises, but also allows you to set some of your goals and values in line with what you feel comfortable with at the moment when you're returning back to perhaps going out a little bit more and in generally understanding your medical condition. There's also another one that's come out specifically for people from a Black and ethnic minority group that looks at some of the additional challenges that people might face when navigating through health systems or other systems as well, and that's called Liberate. These are both at the moment doing free trials, as Abby said. So I think they're doing around 3 months. So you can download it via Android or the iPhone website.
Okay, so I want to take a few questions about interferon, and particularly there is a question about, has a case been made to NICE about ROPEG? Actually, you heard John Mathias speaking about NICE and patient advocacy. There is this NICE submission at the present time underway about ROPEG interferon. There is a question about various statements about production of Pegasus ceasing as well. So I think the complete truth about that is still not clear. We have plenty of Pegasus at the present time. Whether a generic formulation of that type of interferon, which can be very effective for some patients, will be produced. Generic means that's not, it's produced, it's a bit like copies of the Dyson vacuum, if you like. So once the patent runs out on a medication, generic formulations can be produced. So that's possible, but I'm expecting that we will have ROPEG interferon being available, and that agent is being tested also in myelofibrosis, but at the present time it's only approved for PV patients. So Adam, lots of questions here about what is the data about how MPN patients might be affected by COVID? Are MPN patients more vulnerable to COVID? Are they more likely to get a clot? And I know we're gathering information on that, but I just wondered if you might want to comment on that kind of generically.
Yeah, I think the honest answer is that, you know, that there isn't a lot of data out there at the moment. What we know about MPN is, you know, there's some recent data published showing that MPN patients, irrespective of whether they are receiving cytoreductive treatment with hydroxycarbamide or other agents or not, are at increased risk of infection. So it's reasonable to surmise that MPN patients there's a theoretical reason at least why they may be more at risk to develop coronavirus infection. But the reality is we don't have data, and there is a need for us to collect a lot more data here to understand the exact implications for MPN. And it's also important to remember that there are many different types of MPN, so that you can't put everything under one umbrella. It's very likely that the risks will be different. We have collected data in a reasonably comprehensive way from the big centres across the UK. I can't say much about the data yet because we're in the process of analysing it, but it's just to say that the strongest thing that seems to come out of those data is really what we already know from the normal population, that age is a strong risk factor for getting more severe complications of coronavirus.
Oh, he's been saved by the telephone from a follow-up question. Are you good to take a follow-up question, or shall I come back to you with one?
No, I've dealt with it, I think.
You're multitasking. Okay, excellent. There are quite a few questions in the chat about the difference between shielding criteria between England and Scotland, because we heard Mark, who unfortunately can't be with us today, very clearly say that in Scotland had classified myelofibrosis patients as shielded, whereas in England, the clear directive was all blood cancer patients should be shielded. So there are questions about, should ET patients be shielded, or watch and wait patients considered shielded, realising it's the 1st of August and shielding has technically been paused, but could you perhaps comment on how we interpreted that in England?
Well, you know, what we tried to have more of a, I would say, nuanced approach in England to this, and try and categorise from our kind of best expert opinion, I would say, rather than based on strong data, who we felt were at the most risk in terms of MPN patients from the coronavirus. And I you know, my overall sense was the patients at most risk were older patients, particularly those over the age of 65, and those on medications that might lead to a stronger weakening of the immune system, in particular ruxolitinib. I suspect, having seen some of the data, patients who are younger, particularly those who are not on any treatment, are not at a markedly increased risk here, but older patients on treatment are at significant risk and should continue to take sensible precautions. Whether we describe it as shielding or not, I think it's partly semantics. I think it does still pay to be cautious. I think if you have MPN, particularly if you're older or on treatment, it pays to just be cautious and pay particularly careful attention to the social distancing measures and hygiene, all the usual things.
Okay, thanks very much. So Mary Frances, a couple of questions. I can see that Werner is on the line and he's asked, can German patients take part in Mosaic, please? So I don't know whether you want to comment on that.
Not at the moment, unfortunately. We've set it up, and as you say, it's been a long period to do this in a number of UK centres, and hopefully we will have it open very, very soon. We're trying then to get other centres. The Republic of Ireland are looking to set up a centre, and there may well be further ones. Again, we've looked for funding and various things in Australia and the US, but it basically needs somebody in the country to get funding to do it. We would be very happy to get other centres in, but they need to have funding in order to come into the system and collect and do all the regulation, etc. in the country.
Okay, so get the money and you're welcome.
Yeah.
It's the message, yeah. Okay,
yeah.
And then the question that I just told you I was going to ask you. What is the longest time that hydroxycarbamide is known to control MPN?
Right, an easy question, that one. So I don't think there's an answer to that. I've been a consultant now almost for 30 years, which is horrifying. And there are certainly patients that I inherited who were on hydroxycarbamide and continue on hydroxycarbamide. So many, many, many years. Obviously, the disease can progress. It may not control as well as time goes on. But I have certainly patients who live their normal lifespan on hydroxycarbamide, but I couldn't give you an exact answer.
Okay, and then just lastly, there's one about allele burden. Why aren't we tested for it, and can it be checked later?
So it certainly can be checked later. It to some extent is still a research test. It's not really a routine test. And again, the point about why aren't we testing at the beginning, it depends on when people came along and at what point. It's been done mostly in trials to follow the allele burden, because you're trying a new drug, you're very interested to see will the allele burden decrease over time. And I think it will come in more into routine practice. But the problem is that most of the people, their allele burden is probably not going to change greatly over time. What you would like to see is a drug where the allele burden goes down or dissipate, or the mutant disappears. But most of the time that is not the case. But I'm sure Adam and people are doing this more and more as part of following people in a research context.
Okay, Adam, did you want to comment on that? Yeah.
Well, I would just say I think there's probably some regional variation, because our laboratory does routinely report the allele burden in our results. So we do routinely monitor this in the lab, particularly, as you say, for patients treated with interferon. We not infrequently see the allele burden coming down, and I think it is a useful measure. It can also have important implications in terms of understanding the natural history of the disease. So I pushed that reported locally, and we do now report this routinely.
Okay, great, thanks. So Dipti, you gave a beautiful presentation on management and measuring symptoms in MPN at the American Society meeting a year or so back. Could you just kind of talk through some strategies for managing itch, which can be very difficult for patients, please?
Thanks very much, Claire. I think we have to acknowledge that none of us actually, unless we've got that symptom, how terrible itching can be. And there are lots of pharmacological ways, but non-pharmacological ways, I think there are several, and that's been reported by patients. So most commonly, there is the aquagenic itch, where patients step into a shower, they have touched with water, and they find they're extremely itchy. And I think there was some basic stuff that we've learned from patients in the fact that everyone has their own temperature gauge. So practicalities are find a temperature that's appropriate for you when you have your shower. Don't sit in a hot tub for too long. Change the shower head pressure is what patients have reported back, so it's gentle, because what you're doing is you're activating some mast cells in your skin which cause the itching, so that way you're being gentler with them. The other things that have been recommended is when you come out of your shower, dab rather than rub the towels because they make the itching worse. One of the most common things is actually just dry skin, regardless of whether you have PV or not, causes itching. And if you go to any dermatologist, they're just going to say moisturize, moisturize, moisturize. And I think just general moisturization of your skin, keeping it cool, using non-fragrant lotions has been recommended. Some people find calamine can help if they're getting very, very itchy. Dressing in cotton and light clothes, loose-fitting clothes. Again, if you're active and you go to the gym and you're wearing tight clothes, that sweat comes into contact with your skin. So cotton clothes will help. And I guess the other thing is if you're, once the itch starts, patients complain about the fact that they'll scratch and then the itch will spread like wildfire. And it was interesting listening to Abby talking about breathing exercises. A few folk have found that actually using a cold flannel and then using breathing exercises just to try and get on top of that itch to stop you from scratching it, making it spread around your body is very good. And one patient has told me nail care, not having long nails. I know it sounds ridiculous, but having really short nails that are filed. So once you start scratching, you're not actually making that worse. And then there's a whole lot of antihistamines and other medical stuff. But sometimes if it works well. But actually just some of the practicalities that have been shared by patients.
Okay, that's great. And then there is just one more question that's come in online about cough. I think they noticed in Leslie's talk and your talk, Mary Frances, about cough being a symptom of MPN. So Dipti, would you just mind commenting on that? Whether you think that cough is a common symptom?
It's not a particularly common symptom. I think it can reflect the fact that your spleen's got bigger and sometimes your diaphragm can be irritated and that can cause cough. And I think that's one of the ways people can present, unless anyone else has got others. I think it's not a very common symptom, but it is if your spleen's very big.
Okay, that's absolutely great. So
Thank
you very much. Donal, a question for you then. I know you're leading a study on ruxolitinib and COVID, so could you just comment on the utility of ruxolitinib in COVID? And then a follow-up question about what the implication is then for patients with MPN who might be on Rux.
Yeah, so thank you. So I think that you've already highlighted in your question two important aspects of ruxolitinib. So we at Guy's and other centres across the UK and also in Italian centres and previously in China have looked or are planning to look at the use of ruxolitinib as an immunosuppressive agent to down-regulate the immune disarray that can happen as a response to COVID. And we know that in the population, that when patients have COVID who have a severe response to the virus, they get disarray of their immune system. And because the immune system is uncontrolled, it can lead to damage to the lungs, to the vascular system and other organs. And what we're planning to look at in Guy's and St. Thomas's is the use of ruxolitinib for patients who have unfortunately contracted COVID and have a severe illness and are prior to going to intensive care. So their markers of inflammation are high, their breathing requirements are under stress, and their oxygen levels are falling. And in those particular patients, we're planning to use ruxolitinib to try to bring the immune system and harness the immune system under control And what we're trying to do with the trial is to prevent patients having to go to intensive care and be ventilated. Some early data from the Italian and Chinese group in around 20 patients have shown some early signs of efficacy, but of course we have to balance that against too much immune suppression and then uncontrolled viral replication. So to answer Claire's second question, which is what does that mean for us for MPN patients who are already on ruxolitinib? We know that across the board for ruxolitinib, it is an immunosuppressive. So if we think about the front army of immune response called T and B cells, we and others have shown that ruxolitinib suppresses those cells. We also know that in the background, so the second line of defense called the innate immune system, it can also have immunosuppressive effects. And that's why when we look at the shielding guidance for patients, we talk particularly about patients who are on immunosuppressive. If you're on an immunosuppressive agent of any type and you're unfortunate enough to have COVID-19, it may mean that the early immune response to try to keep the virus under control is attenuated. So it's balancing the effects of the immunosuppression at the time of the viral illness.
Okay, so do you think that patients should avoid starting ruxolitinib or lower their dose?
So I think there should be no changes that we've been advising the whole way through since the start of the pandemic in dose alteration of ruxolitinib based solely on COVID-19. The problem with stopping abruptly dose reducing ruxolitinib, irrespective if there was COVID on board or not, would be releasing the brake on inflammation, and there would be a marked rebound in inflammatory molecules, and actually the inflammatory cascade could become under control. I wouldn't abrogate, consider dose attenuation of ruxolitinib. I think we do have to consider commencement of any immune suppressive drug during the COVID-19 era. Clearly, for patients who have an indication as regards either spleen or symptoms for starting ruxolitinib, then I would advocate commencement of the drug as long as there was a clear clinical need.
Okay, that's really clear. Thank you very much. Natalia, there is a question about the difference between primary and secondary forms of disease. So I'm just wondering if you could just, and this is quite complicated, isn't it? So maybe just, if you could just give an answer focusing on that, first of all for myelofibrosis, and then I will probably follow up and ask you again also about high hemoglobin, but let's ask about MF first.
Yeah, so in terms of MF, you have the primary myelofibrosis, which means it's like a new disease. When you have a fibrotic tissue, you have maybe a high spleen, anemia, some change on the your peripheral blood and the bone marrow. And the secondary myelofibrosis is those cases will come from a previous PV or ET patient, so previous polycythemia or essential thrombocythemia, and the patients progress to the most advanced stage, and they present with these changes on the bone marrow, so more scar tissue, fibrotic tissue. They may develop a big large spleen. They may develop anemia or other complications. So that's the main kind of distinctions. In terms of how we treat the patients is pretty similar for us in terms of your primary or secondary, and there's different markers that we use to decide do we need to start treatment or not. In terms of complication, again, it's quite similar. We probably, in terms of molecular, we're probably doing kind of similar investigations. Sometimes you need to be maybe looking further if there's any new mutations when there's a progression from a PV and ET.
Okay, that's great. And just could you just briefly just highlight the difference between primary and secondary polycythemia or erythrocytosis?
Yeah, so in the case of the primary erythrocytosis or polycythemia, you have molecular markers like the JAK2 mutation, which is the most common one. Secondary erythrocytosis will be caused by different other diseases that are not primary hematological, such as lung problems or kidney problems. Some patients, even we don't have a clear underlying reason why they have a high red cells, and we call idiopathic erythrocytosis. Now we have the capacity to, or we've been developing new techniques, and we have investigated for other gene
Okay, that's great. Thank you very much. Claire Woodley, there's a couple of questions that have come up about turmeric and curcumin. Could you just give us your kind of a pragmatic view of kind of how you would address a question about that and what's known about efficacy of that kind of therapy?
So we know that both curcumin and turmeric have been explored with other cancers. Their investigations for their use in kind of MPNs hasn't been widely explored. There was a study that looked at the effect of curcumin on the JAK2 in cells and the JAK2 signaling pathways. What we do know about them, though, is that they're both anti-inflammatory, or their anti-inflammatory properties. So considering that we know there is an inflammatory process with MPNs, they could be used in that way. I think the important thing is that if patients are considering trialing either of these, is that they discuss it with their treating team, because they can interact with some other medications that patients are taking.
Okay, that's great. Thank you for that. Mary Francis, there's a few questions here about interferon. Firstly, is there any evidence that interferon can slow progression or stop progression of disease, especially if the interferon is started at diagnosis?
I don't know whether we have any evidence to suggest that yet. Certainly with some of the interferons, you see a reduction in the size of the clone, and certainly in theory, if you could eliminate the clone, would you get rid of the disease? So there is an argument that it's the agent that will decrease the clone size, and that may be effective in slowing progression. I think what this question is asking is, should it be started up front, or should you wait until patients come into a high risk group with an indication for starting treatment? And I don't think there's enough evidence yet to say that if you started earlier, you can prevent progression. But that may change over time.
What did you think about Professor Barboui's study then that Donal showed us as an update from EHA with regard to using ropeg interferon and venesection compared to venesection alone? What would you hope to see? This is in low risk PV. What would you hope to see from that study?
Well, obviously that is the issue, that if you see on the interferon a lack of decrease of clone size and possibly decreased progression, that would be very effective. But that's going to take a very long time before you will actually see that.
Okay, and lastly, are there patients who are resistant to interferon? And sorry, you're getting all the interferon questions. I just grouped them all together. And how common is it?
So there are two issues with interferon, and the major one would be intolerance. Quite a lot of patients cannot tolerate the interferon, but resistance is a different issue. Are there patients who do not get any effective reduction in their cell counts first with interferon? There certainly are, because I've seen some. I can think of immediately at least one patient in the MAGIC trial who got no response whatsoever to, in the interferon trial who got no response whatsoever to interferon. So there are patients who are resistant. I think they're probably quite rare. I don't have a good feel for what numbers, but there aren't many. And I think you do have to keep trying with the interferon, starting with a very low dose and then building the dose up before you arrive at that conclusion. I don't know whether others think it's more common, but it does happen.
Anybody else want to comment? I'm wondering about just leapfrogging over myself and Adam and bringing in Roselle and Abby, because one of the common issues with interferon actually is low mood. And yeah, I think you've worked with some of our patients who've had low mood, sometimes before interferon. Sometimes we ask you to see patients before and sometimes during. And I just wondered if you might want to make a few comments about that, maybe. I don't know who wants to speak. Both of you, maybe. Roselle, could you comment on managing low mood as a consequence of interferon?
Yes, as you said, Claire, it's something that we receive a lot of referrals about for people that either have already had experiences over their lifetime of low mood, or people that are experiencing low mood and sometimes mixed emotions, sometimes a little bit more anxiety or perhaps anger as a result of the medication. Some people make the choices with the medical team to change the medication, and other people will work with us closely to be able to develop some techniques and ideas around how to manage some of those feelings. Very much it's similar to Abby's presentation. Lots of the techniques within that are really useful for all types of emotions and feelings, regardless of the pandemic. So in terms of, firstly, really feeling like it's normal to be able to feel mixed emotions and confusion when you are starting on new medications and treatment, that can be really anxiety provoking. And also having lots of changes in how you're perhaps working throughout the day. So being able to use some of those techniques, breathing exercises, acknowledging some of your feelings and knowing it's okay to have mixed emotions and that there's nothing wrong with you, that you're not mad or going mad in any way, that it's sometimes a normal reaction to the feelings of medication. If you do have a psychologist within your team, you can reach out and talk to them. But as mentioned in the previous question that we had, there are lots of online resources around ways of managing low mood or mixed feelings without necessarily needing an additional medication. Do you want to add anything to that, Abby?
Not really. I think I would definitely echo what you said, Roselle, about remembering that feeling all sorts of emotions at that point is really normal. And I think a lot of the clients that I've worked with, sometimes what makes it even harder is what you think having those feelings mean and the distress that comes from feeling that way in the first place. So I think the first thing definitely is to remind yourself that that's okay, and there's lots of things you can do to manage some of those emotions.
Okay. I think that's really helpful, and just reflecting that you can get those emotions anyway in response to a diagnosis or a traumatic event, but interferon can definitely heighten them. And yeah, that's really helpful. Thanks. Adam, I'm going to come back to you, and I'm sorry to keep asking you COVID questions, but I will ask you some disease questions shortly. But just really pertinent to your presentation, two common themes are coming up. One theme is vaccine. Will MPN patients be able to get one? Will they be prioritised for it? And you mentioned that the Oxford vaccine was a live vaccine. Is that a problem? And then a comment, please, on coagulation and the interface between coagulation problems, COVID and MPN.
Okay,
you touched on all of these.
I'll take the vaccines first. And the first thing to say about the whole vaccine story in coronavirus is the progress is just utterly remarkable. A process that normally takes many years is happening over weeks and months. And there are over 160 vaccines in development, but there are some lead candidates, one of them being the vaccine from Oxford. Now that is an inactivated, what's called adenovirus, which is a vaccine backbone, you would describe it as, which is derived from a chimpanzee virus. So it's a live inactivated virus. Whether one can use those viruses in MPN patients, I suspect one would need to do a study just to test the safety of that. In fact, I was in discussion with the exact same team that is developing this vaccine about using the exact same vaccine backbone to develop a vaccine approach in MPN. So the direct answer to the question is it going to be possible to use in MPN patients? I think yes, but it's going to be subject to having to collect some safety data relating to that. The other thing to say about that is that it's not the only kid on the block, as it were. There are the so-called mRNA vaccines. One of them, the Moderna vaccine, is kind of quite close behind the Oxford vaccine, and that is not a live vaccine. So even if there were safety concerns and issues relating to the Oxford vaccine approach, that there are likely to be other candidates coming through, and the data looks very encouraging in terms of these vaccines inducing a strong immune response, both the Moderna and the Oxford vaccine. I should say I am not a vaccine expert. I'm just following the literature very, very closely. So we could get a vaccine expert onto one of these panels to give you more comments. I don't know if anyone else wants to comment on the live attenuated adeno approach. I certainly think it would be possible to use that in MPN, but I think it would need to be tested and collect some safety data in a pilot study first.
I mean, I think we would just have to think a bit. So, I think, first of all, these are all going very quickly, aren't they? And generally at the moment, the vaccine is being focused on some healthcare workers who are going to come into contact with COVID and have excluded people with illness. I know because I'm a participant on the study and I just squeaked in. I was just kind of hoping on the grounds of age, etc. So, but I think that really it's only live attenuated vaccines that we think would be a problem for MPN patients. We couldn't see that there would be a problem with other ones.
Potentially a problem, right? I mean, I'm not aware personally of any data that these types of vaccines have been a problem in MPN. So it's a theoretical problem, and I think in that situation one has to balance the risks and benefits. And I think clearly, if the Oxford vaccine comes through and shows really good efficacy in the big clinical trial, I think there would be quite a strong incentive if the other vaccines were not, were substantially far behind the Oxford vaccine. There would be quite a strong rationale for testing that in MPN. I would argue.
I think as well, we all have to weigh up risk and benefit, don't we? I think there's another clear message here is, please get your flu vaccine this year. When you get offered a flu vaccine, please get the flu vaccine. The NHS will be having a massive push on that. There was a question about a flu study that was done, guys, and we'll update you on that at some point. We've just submitted it for publication, and that looks at the way that the immune system responds in MPN patients to flu. And maybe Donald, do you want to comment on that, the flu vaccine and the MPN?
Sure. So this is work that many of us on the call and others were involved in, guys, really looking to see how patients with an MPN, how their immune system responded to the annual influenza A vaccine compared to individuals who didn't have an MPN. So what we've learned from that in brief is that the immune response can be slightly less so for those patients with underlying MPN compared to others, but there is an immune response. And that's the most important thing, that although it may not be as robust an immune response as individuals who do not have an MPN, but an immune response, and it's built on each year that all of us receive the vaccine. Just to finally comment on influenza vaccines and COVID, I saw one question that was asked, does influenza vaccine give any degree of protection against COVID-19? So the two viruses are completely different. So the way the vaccines are designed, the answer would be a no. The neutralizing antibodies and the initial immune response COVID-19. However, when they've looked at almost 90,000 Brazilian patients and split the groups based on those Brazilian patients, because their flu season is earlier, it's April and May, those patients who had been challenged with a vaccine actually had a less severe course with COVID-19. And that's not because the vaccine itself stimulates the immune response to COVID, but it backs up the immune system. This means the immune system is more alert and reactive. And when challenged with COVID, certainly in younger and older individuals, the disease course with COVID was much less. So that again gives us a very strong rationale for all of us to have the entry.
Okay, great. So back to you, Adam, just to comment on clotting. I said I would ask you about that. Yeah.
Just to very briefly finish off on the vaccine, because the other issue that you asked me about was whether MPN patients would be prioritized. Again,
yes,
you know, these kind of decisions are going to be made at an extremely high level and not by me. But I suspect there will be targeted vaccination going to the high risk groups when a vaccine becomes available. And I would imagine MPN patients would fall into that category as they've been advised to shield. But again, you know, we have to wait and see what vaccine comes through and what the government guidance is. On the clotting and vascular problems, I mean, clearly it has emerged from many different studies now that at the heart of the really severe end of the spectrum of coronavirus disease is what's called a vascular injury, where you get this severe inflammation, which can be in the lung, but it can affect other tissues such as the kidneys, the heart, the brain. And it's a complex interaction between the inflammation driven by the virus and the blood vessel walls and the clotting system, and that can drive all sorts of problems with actually getting blood clots, and which themselves cause damage kind of indirectly as a result of the virus. So that's very clear. There is, I would say, circumstantial evidence that if you more strongly anticoagulate or thin the blood of patients with severe disease, it does protect against worse outcomes. But that is not what I would say the kind of gold standard type of evidence, which is randomized controlled trial data. Those studies are now being done in the UK and elsewhere. So we will get an answer about the role of blood thinners in the management of the disease. Specifically relating to MPN, I go back to my previous answer. I'm afraid we don't yet have enough data, certainly no data to suggest that MPN patients are at increased risk. You could argue that MPN patients should already have optimal control of their blood thinning and vascular risk factors, which may well be, you know, to a certain benefit that most patients will either be on aspirin or some form of blood thinner in advance. I don't think there's any suggestion or evidence at the moment that any of those medications should change. There was some debate about aspirin early on, but there's no evidence that there's any problematic role for aspirin relating to coronavirus. So those medications should not change, and everyone should continue them as recommended.
Yeah, and remember that we treat you to reduce generally the risk of clotting, so ideally should be optimised. And obviously, now we can start monitoring patients again more closely. This will be fine. I saw a question online about will I ever be able to have a face-to-face appointment at Guy's Hospital? So I think we can answer the question, yes. We actually, Rosella and Abby, you've been using Attend Anywhere, which is a kind of video appointment app, isn't it? So I don't know whether you want to comment on that and how you found that.
We've had lots of questions around when people are going to be coming back to the hospital, and that goes similarly for when people are going anywhere really, back to work or back to other environments. The hospitals are all working very hard to make sure that the hospitals are COVID secure and safe, which allows for social distancing. We've also had some really good feedback so far on virtual platforms like this, where people have found it really helpful to be able to not have to travel long distances or commute, or necessarily have to get fully dressed to be able to then attend their appointment. So we found for lots of people, they've really valued being able to have either psychology sessions or contacts online. And the systems, we were a little bit worried about them being quite complicated, but actually you get given a text message reminder appointment in the same way that you would your usual appointment. And there's a link. You don't need to download anything. It comes up on your usual Internet Explorer page. Enters you into a waiting room, and then you can enter and join with either one clinician or multiple clinicians, so you don't miss out on seeing different people as if you were to come to the hospital. So we found it really good so far and really accessible for most people. But of course, we like to be able to see people. We like to be able to have those familiar informal contacts in the corridors and say hello to people when they're in the waiting room. So we do definitely look forward to people coming back and seeing both us and all of your medical teams when it feels safe to.
Yeah, and we can see some patients face to face. We are working very hard to keep the environment as safe as possible. Probably we won't ever go back to, hopefully never, go back to the massively overcrowded waiting room with people standing in the corridor waiting to be seen. We never liked that in the first place. But we definitely are. And if you do want to come to Guy's, there's a lovely video on the webpage from our chief nurse and infection control lead about how safe the hospital is. So Dipti, I'm going to come to you now with a couple of questions that have come up about hydroxycarbamide, actually. Something about long-term complications, and something about links between migraines and platelets and hydroxyurea.
Okay, thank you, Claire. So as Mary said, hydroxycarbamide you can use for a long, long time if you're stable, and we've had patients on it for more than 15, 20 years or so. I guess the long-term effects, one of the commonest side effects of hydroxycarbamide affect the gut in some way, initially with nausea, vomiting, bowel changes and constipation. And they can continue for a while if patients have them and they're reasonably well managed. The way hydroxycarbamide works is by affecting the DNA in repair in cells. And so long-term, very long-term, one of the concerns is about making sure you look after your skin. There's an association with skin lesions, either benign or some skin cancers. So the advice is, if you are on it, make sure that you are using sunscreen, make sure that you're actually taking care of your skin and being aware of it. So if you do see or notice any lesions, you let your clinician or your GP know so that they can be looked at. And that's, skin lesions and skin cancers are common anyway, but there's a link with hydroxycarbamide long term for that. Skin changes, which usually happen in people with slightly darker skin, so you can get changes in skin discoloration and nail discoloration, and that affects people in different ways to different degrees. And then I guess fatigue is associated with it, but then fatigue is a very complex symptom to try and manage, so it may not all be hydroxycarbamide. And then I guess the long-term biggest question is about whether or not there's an increased risk of leukemia with hydroxycarbamide. And I guess what I would say for that is there were some studies done by the French group about almost 8 years ago now, and the broad outlines for those were those patients that had hydroxycarbamide with PV, it was done with PV patients and had venesections, there wasn't an increased risk between those groups, it was hydroxycarbamide alone. But if patients had hydroxycarbamide and another drug, another alkylating agent like busulfan to control their platelet counts, they had a slightly higher risk of having progressing onto something called myelodysplastic syndrome or leukemia. We know from our studies from patients with sickle cell disease there isn't an increased risk of leukemia, but we have to bear in mind that patients with MPN have an underlying problem with the bone marrow in terms of mutations, so that's what increases the risk. I think those are the long-term, main two long-term risks that I can think of, unless I've missed something from my colleagues.
No, that was great. And then just briefly, could you comment about migraines and platelets before we move on to ask the last couple of questions?
There was one about, I think there was one about migraines, platelets and hydroxycarbamide. I'm not sure there are two different things. If you have high platelets, then you get microvascular symptoms. We know there's definite an association between having a higher platelet count and people suffering from migraines because they get it's part of the microvascular symptoms. Whether hydroxycarbamide, it causes headaches, but I don't think there's a direct association with migraines. I think It's the fact that you have higher platelets. Once the platelets are managed with hydroxycarbamide or any cytoreductive therapy, patients' migraines seem to get better. You might get, one of the other things is you might get platelet cycling. Some patients have platelets that are quite high, so it takes a while for the hydroxycarbamide to control their platelet count. And it may be that's what's causing or consistently leading to the migraines being there.
Cool. So G asked a question for Donal. Upper age of transplantation. Do you want to comment on that?
Yeah, so that's quite clear for us across Europe. Most of us within the field of MPN and transplant would consider allograft up to the age of 70 years if the patient had no major significant comorbidities and had an eligible donor.
Okay, great. You were more succinct than I was expecting then. And that's just about CALR mutations. Can you just talk to us about different types of CALR mutations? And then just a last question to Claire Woodley then after that.
Sure. So there were two major publications in 2013 looking at the incidence and relevance of CALR mutations in MPN. So that's really around 1 in 4 patients with myelofibrosis or ET have one of the CALR mutations. There are around 50 different calreticulin mutations or more that have now been reported, but the vast majority of patients have type 1 or type 2. And you'd also see some reports that say type 1-like or type 2-like. Calreticulin has multiple functions within the cell, but indirectly the mutations will lead to upregulation of JAK-STAT signaling. So the differences are compared to JAK2 mutations, often patients are younger, they often have a higher platelet count, a lower white cell count, and the initial studies suggested a lower risk of thrombosis, but actually on reflection, that most likely reflects the younger age of individuals with calreticulin. And for myelofibrosis, if you think, or for ET, for CALR type 1 and type 2, often type 2 has a higher platelet count than type 1. There can be different mutations that are non-driving mutations in the background, differing between type 2 and type 1. And those would be the major differences between type 2 and type 1 calreticulin mutations.
So it's probably important, is it, to know which type of CALR mutation you have if you're a patient with one of them?
I think it is important. I think we certainly in our centre will type the CALR mutation. I think we're learning more about calreticulin. We know that on some therapies, as other panel members have discussed today, there can be, it's not as sensitive to interferon as JAK2, but you can see changes in the percentage of calreticulin mutation. So I think as we move forward with more appropriate stratification and molecular stratification of patients, it would be important to know the type of calreticulin mutation that has been assigned within the lab.
Okay, that's great. And then Claire Woodley, you get the last question. Just about measuring symptoms, because that's so important. It's a massive impact on quality of life, important in terms of measuring benefit of treatments, etc. Just can you just comment on how you recommend measurement of symptoms? And there is a question about MPN app as well.
Yeah, so within our centre we use the MPN 10 symptom assessment form. So this is a form which helps patients to grade their 10 most common symptoms that we find are relevant to these conditions, and they get to grade them on a score of 1 to 10, or 0 to 10, sorry, 0 being non-existent to 10 being the worst for them over the last 24 hours. Now this is a very individualised score. But what it helps us to do is to track over time how their scores are changing. It also is helpful for the patient because sometimes it can be when you come into a consult, it can help you focus with the clinician on what is most important for you. And as you said, it can help with tracking the impact of treatments onto how your symptoms are responding to the treatments. As you mentioned, there is an app. It's called the MPN Assistant UK, and it's an app where you can download onto both iPhones and Android phones, and it helps you. It has the MPN 10 form on there, and you can score your symptoms quite easily as a scroll through on the app. It can then be emailed to your clinical nurse specialist or to your treating team so that they can have that ahead of your clinic appointment if you wish, and can be able to discuss it with you then in your appointment. On the app, you can also make notes of your blood results, which can be important if you end up in a different hospital, because you can have that information with you. When you download the app, it will only work on the device that you download the app to. So if you have it on your iPhone, it won't then transfer to your iPad. It is only on the one device that you download to.
Okay, that's absolutely fantastic. And I can't believe an hour's gone by already. So thank you very much, everyone. I'm going to hand back to Nona. We gave you a break. We didn't ask you any questions. I didn't think you wanted any. So I'm going to hand over to you to close now, Nona. Thank you so much.
Thank you all. And on behalf of MPN Voice, I'd like to say a huge thank you to all the clinicians who have given up a Saturday morning to give us some amazing insights and information to living with an MPN. I'd also like to thank Andriana and the team at Brandcast Health who've been helping us with all the technical side, and endless patience with a technophobe like me. Thank you. And just one other thing to remember, that on the 10th of September, it's the MPN Awareness Day. Please keep an eye on the website to see the plans we have to raise the profile of MPNs. Finally, thank you all, and thank you all of you listening and taking part. We look forward to the next online forum, whenever that's going to be possible. And the main thing is stay well and keep safe. Thank you, everybody. Goodbye.
Thanks. Bye, everyone.
Thank
Thank
you.
you. Bye.
Bye.